Good afternoon, everyone. My name is Laura Hepkessel. I'm with the SIU School of Medicine, and I also serve on the Board of Directors for Rural Partners. I'd like to thank the University of Illinois Extension for teaming up with Rural Partners to offer webinars throughout the year focused on important topics to rural areas. We've got a few housekeeping items. We have a lot of people on the line, which we're excited about. If you could make sure you keep your mic muted, that would be helpful. If you have questions or comments, please put those in the chat space, and we'll address those at the end. If you're having any audio difficulty, you can post those questions in the chat and we'll provide technical assistance. We are recording this webinar and it will be available later on the U of I website. You'll get an email when that recording is available. And if you didn't register for the webinar directly, Nancy will include some instructions in the chat box on how to register so that we can make sure you get the follow-up email. I'd like to welcome you to today's webinar titled Telemedicine and Maternal Fetal Medicine, Improving Maternal Care Throughout Central and Southern Illinois. This is the second in a three-part series focused on rural health. The first webinar, which was earlier this week, was focused on area health education centers and their focus on healthcare workforce education. The third webinar is on March 21st, where we'll learn about OSF On-Call and their digital health programs. This month's Rural Health webinar series and other webinars are offered by the University of Illinois Extension and Rural Partners. Rural Partners is the state's Rural Development Council. We're a member-driven organization with a volunteer board. If you'd like to learn more about Rural Partners, I'll include our website link in the chat. We are always looking for new members and we would love for you to join us. Now on to today's webinar. I'd like to introduce my colleague, Dr. Rob Abrams. Dr. Abrams is the Director of Obstetrics for the South Central Illinois Perinatal Center. He's also the Executive Director and Professor of Maternal Fetal Medicine at SIU School of Medicine. I have the honor and privilege to work with Dr. Abrams regularly. And now I'm going to pass it over to you, Dr. Abrams.
Thank you so much, Laura, for the introduction. And I want to apologize at first for my raspy voice, but the game was quite exciting. The Illini game 2 days ago against Purdue. So I think I was cheering a little bit too much, but hopefully you can all understand me. Excuse me. So the objectives today, I want to demonstrate challenges in Illinois that we have in order to provide equitable obstetrical care for all patients. I want all of us to understand the challenges of providing high-risk obstetrical care throughout the South Central Illinois Perinatal Network. I'm going to review how SIU, Southern Illinois University, Maternal Fetal Medicine, expanded its program through the use of telemedicine. And then I'm going to acknowledge the many benefits of telemedicine in providing high-risk OB care. And then to give a very brief personal background, I grew up in Deerfield, and that's a northern suburb of Illinois. I went to University of Illinois, Urbana-Champaign. I went to medical school at Rush Medical College in Chicago. I did my OB/GYN residency at University of Illinois Chicago Medical Center, and then my maternal fetal medicine fellowship at Loyola University Medical Center. And then I moved to Springfield to work for SIU School of Medicine here in the state capital for the past 17 years. So I've really seen the challenges of providing obstetrical care in Illinois, both from an urban perspective, from my training in Chicago, and of course, in my current job in a rural region. And what I wanted to start with is just to describe the Illinois Department of Public Health regionalization of perinatal care. And Illinois is fortunate. We're one of very few states that actually have a formal plan for regionalization of perinatal care. So each geographical region in Illinois has a level 3 administrative perinatal center responsible for ensuring that patients are receiving care at the appropriate hospital level. So again, just to go over this, level 0 hospital, that's a hospital in Illinois that provide no obstetrical services. So if you're a pregnant woman and you go to a level 0 hospital, unfortunately, there's not much they can do, and they're going to have to transport you to a higher level hospital. Level 1 hospitals provide care to very low-risk pregnant women and newborns. These are typically women who are term, so 37 weeks and above, and low risk. If you have moderate risk, you typically have to go to a level 2 hospital, and the highest risk hospital in Illinois are level 3 hospitals. And these are the hospitals that provide care for patients requiring the most complex obstetrical and neonatal care. So the South Central Illinois perinatal center at HS St. John's Hospital in Springfield, which is where I work. We are one of 10 administrative perinatal centers designated by IDPH to oversee a regionalized perinatal healthcare program. And just so you understand how much we have to cover, so of these 10 administrative perinatal centers in Illinois, 6 of them are located within Chicagoland. And so there are only 4 administrative perinatal centers that cover the remainder of Illinois, and they're located in different regions. So in the northern region, you have Rockford. In the north central region, you have Peoria. In the central region, you have Springfield. And then in the southern region of Illinois, they're actually cared for in St. Louis. Obviously, the population in Chicago is quite larger than other areas in Illinois. So that's why there's so many perinatal centers in Chicago. However, despite the larger number of babies being born in this region, the distance to a delivering hospital is much closer than in the other regions, which I'm going to show you. So this is a map of the entire state of Illinois, and it denotes where these level 3 high-risk obstetrical administrative perinatal centers are. So if you can see up here, this is the where Rockford Memorial Hospital is, and all these other sites in green are smaller hospitals. They're part of the Rockford network. If you move towards the north central region of Illinois, you get into the North Central Illinois Perinatal Network, which is housed at OSF St. Francis Medical Center in Peoria. So you can see that that one administrative perinatal center has to provide the high-risk OB services for this entire region of Illinois. Moving south to the blue area, which is where I work right here in Springfield, Illinois at St. John's Hospital, we're the South Central Illinois Perinatal Center, and we're responsible for taking care of obstetrical patients throughout this entire region. And then here in the orange is SSM St. Mary's Hospital through St. Louis University. So you can see there's only 4 administrative perinatal centers taking care of the highest risk pregnancies for all of Illinois, other than Chicagoland. And I should note that specific to the South Central Illinois Perinatal Network is Carle Foundation Hospital, University of Illinois in Champaign. They're also a level 3 center. So for our specific network, for all that blue, we have 2 hospitals where high-risk obstetrical patients must go to, compared to the abundance of level 3 hospitals in Chicago. Now, this slide is an enlarged representation of Chicagoland, and Chicagoland consists of course, Cook County, where Chicago is, Lake County, DuPage, and Will County are the collar counties. So within this region, there are 6 administrative perinatal centers. And you could read here, there's University of Chicago, Stroger Hospital, which was the old Cook County Hospital, University of Illinois, Chicago, Loyola University Medical Center, and Rush Presbyterian St. Luke's. So specific to our network where I work, South Central Illinois Perinatal Network, I think this is a really nice map which paints a good picture of how much land we need to cover. And having grown up in Chicagoland, a common sentiment was that the state of Illinois really ends at Interstate 80 or right about here. So most people in Chicago and those who grew up in the northern and western suburbs, we really thought that Illinois pretty much ended here. And we didn't give much thought to all, 3/4 the rest of Illinois. Now that I've lived in central Illinois for a long time, I have a full understanding of just how large our state is and how all pregnant women in Illinois must have access to the same level of obstetrical care, no matter where they live. Whether they live in Chicago, we all know where Chicago is, that's a population of 2.7 million. But even if you live in Valley City, which is in Pike County here, and that's only a population of 12 total people. But my point is, no matter where you live in Illinois, if you're pregnant, you should be able to have access to high-risk obstetrical care and equitable prenatal care. So I'm sure people have seen this before. This slide demonstrates what many people outside of Illinois, and even those within Illinois who grew up in the Chicago area, think about our state. You have the big city of Chicago, and you have the Sears Tower, or I guess you're supposed to call it the Willis Tower. and then the rest of Illinois, which is all cornfields and cows. But there is some truth to this once I show you how much of Illinois is rural with the limited OB providers in the rural areas. So going back to the South Central Illinois Perinatal Network, which is again in this green area, we cover a population of 1.5 million people, 37,500 square mile geographic area. So we cover all the way from the eastern border of Illinois with Indiana, all the way across the state to the western border, which is the Mississippi River. In our region, in the green areas, there are 12,000 births annually out of 130,000 in Illinois. So about 10% of the births in Illinois are from this green region. And there's pretty much roughly 10% of births from each region outside of Chicago. So in the Rockford region, they do about 10%, Peoria region, 10%, Springfield and Champaign region, 10%, and then the southern region, 10%. So that means that the remaining 60% of births are in Chicagoland. And if you look at the number of hospitals that deliver babies in the South Central Illinois Perinatal Network, well, there are 30 hospitals, but less than half of them actually deliver babies. And that number is steadily decreasing over the recent years. And what's happening is this is making the distance that pregnant women and their families have to travel much greater, which is leading to creation of what we call obstetrical deserts, which I will discuss later on. And of course, in the spirit of all women having equal access to prenatal care in Illinois, this certainly includes the 2 women's correctional centers through the Illinois Department of Corrections. One is at Logan Correctional Center, which is located in Lincoln, Illinois, about here, and Decatur Correctional Center. And these women all deliver at HSHS St. John's Hospital in Springfield due to their high-risk status because of poor social determinants of health, which are defined as the non-medical factors that influence health outcomes. So this slide demonstrates the density of deliveries in Illinois. So like I previously mentioned, about 60% of babies that are born in Illinois are born in Chicagoland. However, that still leaves 40% of pregnant moms to be cared for in the rural areas. So the darker the color, the more babies that are born. So clearly you could see in the Chicago area and the collar counties, that's where the bulk of the deliveries are 60%. But then you still have 40% of deliveries throughout our entire state. And this shows you the drastic difference between the distance from a delivering hospital in Chicagoland versus rural Illinois. And I used central Illinois as an example. So if you live in suburban or urban Chicagoland, there are 75 delivering hospitals, which cover 9,581 square miles. So there's pretty much one hospital that delivers babies in Chicagoland for every 127 square miles, or basically every 10 by 10 square mile radius in Chicagoland, there's a hospital that can deliver your baby. Now compare this to rural Illinois. So in our network in central Illinois, there are only 13 hospitals that deliver babies, and we cover 37,500 square miles. So basically there's one hospital for every 2,800 square miles. So basically to simplify this, if you live in central Illinois, that means that women on average have to travel 22 times farther to find a hospital that delivers babies when compared to Chicago and its surrounding suburbs. And just to show you what's happening in the United States, and Illinois obviously is not immune to this, is that many rural hospitals are closing. And of these rural hospitals that do remain open, some still choose to remain open, but when they're going to cut services, the first thing they cut most of the time is maternity services. And I'll explain to you soon why that happens. But I just want to show you, this is 2022. This is 2 years ago. So over here are the level 0 hospitals or the non-delivering hospitals. So in 2022, we had 15 delivering hospitals. And of those 15 delivering hospitals, again, there are only 2 hospitals that can take care of high-risk patients. That's the hospital I work at in Springfield, St. John's, and Carle Foundation Hospital in Champaign. So all the high-risk patients have to be transported. So if you're a high-risk patient from this level 1 hospital, level 2, and you have an obstetrical complication, you have to deliver here. Well, now let's fast forward 2 years and look what's happened in just a 2-year span. 3 of our hospital network closed. 3 of our hospitals that did OB services closed, leaving only 12 obstetrical hospitals open. Now, thankfully, 1 hospital just restarted their obstetrical services, so we do have 13 delivering hospitals in our network. But basically, in 2 years' time, the number of OB hospitals in central and southern Illinois have reduced or decreased by 20%. So to demonstrate how timely and urgent the issue of hospitals closing their OB units is, this is actually the lead article from the Journal of the American Medical Association from just 2 weeks ago. So you can see down here, this is published in JAMA, February 21st, 2024. And this picture was on the front page, and the title is "More than half of US rural hospitals no longer offer birthing services. Here's why." And unfortunately, this is becoming more and more frequent across the country, and certainly in our state of Illinois. And I just want to take the time that I would be very remiss without mentioning how incredible our rural OB providers in Illinois are. And I could speak specific to the Central Illinois Network providers with whom I have formed a strong relationship with. These healthcare providers have the most difficult job. They have to care for many pregnant patients in smaller hospitals that may have limited resources, and their dedication to their communities is truly amazing. So really, we're very fortunate in our region to have such wonderful OB providers who care for these women in the less populated regions. So as more hospitals close, the distance obviously to a birthing hospital is increasing. So in this map of Illinois, the darker the color, the farther women have to travel to have a baby. So you can see here, as comparison in Cook County, Chicago, and the surrounding counties, most women at the most have to drive 10 miles to get to a hospital that delivers babies. As you move further south, compare that to Southern Illinois, Carbondale, where almost all families need to drive up to 50 miles just to find a hospital that will deliver babies. And you could see where I work, which is where the arrow is in Central Illinois in Sangamon County. Luckily, we have 2 hospitals in Springfield. So if you live in Springfield, you don't have to drive very far. But look at all the other families in our network. They typically have to drive anywhere from 20 to 50 miles just to deliver their baby. And even worse, if a patient needs to be transported to Springfield because she's high risk and she can't deliver at a lower hospital closer to home, it can take hours for the patient to get here. And we have a very robust transport service, and we either utilize our ground transport team via ambulance or our helicopter team via air. I know you can't see this, but just outside my window, I can see the helicopter pad where our 2 helicopters are housed. Right now, there are 0 there, which means both helicopters are out on transports. So it's helpful to know exactly when our patients arrive. And I know this chart is very busy, but all of my partners use this chart because it gives them an idea how far these hospitals in Central Illinois network are by ground and by air. So let's use Blessing Hospital as an example. And I saw some physicians from Blessing on our call, so they could attest to the challenges they have on trying to get their patients transported to a higher level. So if you look over here, it takes 2 hours by ground just to get to Blessing Hospital and 50 minutes by air. So you have to account for our maternal transport team to go get the patient and bring her back. So maternal transport from Quincy typically takes a total of 4 hours for her to get here by ground and about an hour and a half hours by air. And mind you, this is in ideal weather conditions. Oftentimes, such as the winter weather now, precludes us from flying. And the rural interstates, and I've driven them many times, may make these transports more difficult and lengthy. On average, St. John's Hospital accepts about 350 maternal transports per year. And that number continues to increase every year due to the worsening medical complications that we're facing, such as severe hypertension, morbid obesity, and diabetes, to name a few. So what happens when hospitals close their maternity units? Well, it places a greater burden on those that are still open. So here's a graph of deliveries at my hospital. And you can see that just over the past 6 years, our deliveries have increased by almost 20%. Now, I think this is happening for two reasons. One is clearly because fewer hospitals are delivering babies in central and southern Illinois. So women have to go to Springfield because that's the closest hospital. But also the second reason why our deliveries are increasing is because there are more maternal transports, as I spoke about in the previous slide. And I see this number only increasing year after year. So what is the true definition of a maternity desert? So the true definition is any county that without a hospital or birth center offering obstetric care, or that doesn't have any obstetric providers. So even if a county doesn't have a hospital, it's still an obstetric desert if there's not even one OB provider in that county, which is scary to think about. But this is a map of Illinois, a map of the United States, and you could see a lot of red, and the red is where there are maternity care deserts. And now I'm going to move on to our specific state, and specific to Illinois, 1/3 of counties are maternity care deserts, and another 20% of counties have moderate or low access to obstetrical care. And so you can see, dividing those regions I talked to you about. In Rockford, there's a couple areas that are deserts. In the Peoria region, there are some deserts. In Central Illinois Network, besides Sangamon County, which is Springfield, most counties are deserts or have low access to maternity care. And you could see, look what's going on in the southern region of Illinois. So I think this map clearly shows you how much a need there is for maternity services in outside of Chicagoland. This slide shows the proportion of rural hospitals in our country without labor and delivery services. So believe it or not, Illinois is only one of 10 hospitals in the United States where more than 67% of rural hospitals do not perform deliveries. So 2/3 of the hospitals in Illinois do not deliver babies. And in a minute, I'm going to show you a video. It's just a 4-minute video, which describes some reasons why rural hospitals close their OB units. And some examples provided are due to staffing difficulties and financial challenges. But what's interesting when you talk about financial challenges, this map shows you which states actually make money and which states lose money having obstetrical services. And even though many hospitals claim that financial loss is a major reason to close their maternity wards, in Illinois, 70 to 90% of Illinois rural hospitals actually make a profit by having maternity services. So what I want to show you now is a 4-minute news story from NBC World News. It aired early last year, and it describes a real-life example of what might happen if a pregnant woman lives too far from a hospital that delivers babies. And although this story is from Connecticut, I can clearly tell you that I have seen this story occur over and over in central and southern Illinois.
Within a decade now, rural hospitals have been shutting down their maternity wards. These medical facilities are closing their units in part because of financial struggles and low patient numbers. But closing these units could put expectant mothers in real danger if an emergency happens. NBC News correspondent Stephen Romo has this report.
I had woken up at around 11:30 and I stood up and I was bleeding very heavily.
During her second pregnancy, Rachel Tuberville's condition became harrowing in just a matter of minutes.
I was experiencing a placental abruption and my baby was having heart decelerations.
Within an hour of arriving at Sharon Hospital in rural Connecticut, Rachel had an emergency C-section to deliver her son Colin.
I think that being so close to a hospital made it possible for everything to work out the way that it did.
But that care might not be available much longer for expecting mothers in Sharon. The hospital's owner, Nuvance Health, is currently seeking regulatory approval to close the maternity ward. In a statement to NBC News, Nuvance said it has faced continuous financial challenges and low patient volume in the labor and delivery unit. But for most people, that would mean a 45-minute drive to the nearest hospital at least.
Time is of the essence.
Dr. Howard Morgman delivers babies at Sharon Hospital and has a private OBGYN practice. He was part of Rachel's care team after her pregnancy.
She's another example of if Sharon Hospital isn't there in that proximity. I don't know that Rachel's around. I certainly don't know that her baby's around.
Dr. Morgman also has a more personal connection.
My sister, Gail, she is disabled because of delay in care at her birth. And I said, I'm going to become an obstetrician. I'm going to dedicate myself to preventing what happened to my sister, Gail.
But maternal care has been disappearing from rural communities for more than a decade. In 2004, 898 rural counties did not have hospital obstetrics units. By 2018, an additional 200 rural hospitals were without labor and delivery services, according to researchers.
We're in the midst of a maternal health crisis. The CDC tells us that about 60% of pregnancy-related deaths are preventable.
Experts say rural hospitals in America are more prone to staffing and financial challenges because they serve a higher proportion of low-income families in areas with fewer births.
These vital resources are leaving communities that often need them most.
Back in Connecticut, Sharon Hospital must first get approval from the state to end birthing services. But Connecticut's Office of Health Strategy confirms to NBC News that they're actively investigating whether Sharon Hospital illegally terminated its birthing services without a state-required certificate of need. In a statement, Nuvance Health said that Sharon Hospital was committed to working with OHS and that they have closely followed the process required. But as we await a decision from OHS, the labor and delivery unit remains fully open and operational. 4 years later, Rachel says she and her son are both perfectly healthy.
To me, it's scary to think about what could have happened with that extra hour added onto an already very scary situation. I don't really know what would have happened.
And we should mention the U.S. has the highest maternal mortality rate in all high-income countries. And as for Sharon Hospital specifically, the next step in the process is a public hearing that's set to take place this month so members of the community can weigh in about what this closure would mean for them.
Okay, so up to this point, I've really just spoken about the difficulties that pregnant women encounter at the time of having their baby. But we all know that there's 9 months before women go to the hospital to have their baby. So what I'd like to speak about is the challenges that I face as a high-risk OB doctor to provide adequate high-risk prenatal care to our huge region and how patients can gain access to this care. So this slide shows how we've grown our center to do our best to provide high-risk OB services to all of Central and most of Southern Illinois. I moved from Chicago to Springfield in 2007, and that time it was just myself and one other physician, and he was at the latter stages of his career, and he did mostly administrative work. So it was quite daunting to attempt to provide care with just basically 1.5 physicians. Then over the years, we built up our group with outstanding maternal fetal medicine physicians who are all dedicated to providing compassionate high-risk OB care. So Dr. Thompson came in 2008 from Chicago. Dr. Unal came in 2012, and she's from Central Illinois, and she came back to serve the population. Dr. Atacola joined us 6 years later from Michigan. And then Dr. Sangaroth, who's from Central Illinois, from Vandalia, and trained at WashU in St. Louis, she joined us in 2019. And we're currently recruiting for another physician and hoping to get another one by July of 2025. This is Emily Martin. She's our nurse practitioner. Melissa Nickel is our certified diabetic educator who takes care of hundreds of diabetic patients in pregnancy. We have a perinatal coordinator, Kelly Jones. We have 2 certified genetic counselors, 15 sonographers. And just to give you an idea, when I started, we only had 2 full-time sonographers, and now we have 15 and we're recruiting for more. We have 3 nurses, 3 medical assistants, 4 front desk staff. So this just shows you need way more than physicians to provide high-risk obstetrical care. We are just a very small component of the entire cog in the wheel. We really need an entire team to achieve our goals of providing equitable care to all women, no matter where they live in Illinois. Now, this is straight from Illinois Department of Public Health, which quotes, "All pregnant patients should have equal access to high-risk obstetrical care, regardless of ethnicity, race, socioeconomic status, or distance to a level 3 perinatal center." So basically, this translates to wherever a pregnant woman lives in Illinois, she must have the same access to high-risk OB care. And this is the daily dilemma that we encounter when we practice high-risk obstetrics in rural Illinois. And several years ago, abiding by these IDPH rules, we had to find a way to provide access to care for all of these women. So it was quite overwhelming when we thought about, how are we going to do this? How can we give care to such a huge region? How can we see all of these patients in our small office in Springfield? Well, there's certainly barriers for patients to get here. And I just listed a few barriers, but one major barrier is transportation. So in central and southern Illinois, a lot of patients don't have vehicles, or if there's no public transportation, like you can hop on the L in Chicago, there's no real good bus routes that can take you from Quincy, Illinois to Springfield or Champaign. And if you've lived long enough in Illinois, I'm sure you've heard somebody say this quote: "If you don't like the weather in Illinois, just wait an hour and it will change." So this cartoon kind of shows you what happens in Illinois. So in Arizona, it's always hot. Wisconsin, it's always cold. Washington, it rains all the time. And Nebraska, it's always windy. But in Weather Illinois, we could experience all of this weather on a typical Thursday. Last week's a perfect example. My 2 sons, who are students at University of Illinois, they sent me a photo from the quad, and it was packed with students in shorts, and they were playing Frisbee. And the next day I get another photo from them. And this time it was a photo of an empty quad, which was covered with snow. So, weather plays a big role, especially when they're traveling for hours. And then we have to ask ourselves, is it really safe for a high-risk patient to sit in a car for hours to come to see the doctor? Because, pregnancy, sitting in a car, that places you at increased risk for blood clots and other complications. Another barrier for patients to come to Springfield is time. They have to take off a full day of work. And I often tell my patients, and I kind of joke with them, but it's really true, going to see the high-risk OB doctor really becomes a full-time job throughout the pregnancy. And money, we have to talk about money, the cost of gas, the loss of income by losing a day of work every time you have to see the doctor, the cost of childcare if you can't bring your kids to the office. So there are great barriers for patients to come to us. So the question is then, if patients outside of Springfield have a tough time getting to their appointments, how do we provide equal access for them? Well, if they can't get to you, then you need to go to where they are. So we thought, okay, let's make a dent into this challenge, and let's start going to Quincy. So we started driving to Quincy every Thursday, and we started that in 2010. And then we started in Decatur. So you can see this is where we're located in Springfield. And every Thursday, one of the physicians drove to Quincy to see patients, and it was a 4-hour round trip. But we felt that was the best way we can provide access for these patients. And what's interesting, here's this red dot is Decatur. And even though Decatur is only a 45-minute drive from our Springfield office, it was still very difficult for many patients to get to us due to the reasons I previously mentioned: lack of transportation, or it's just too costly for them to drive. So these women, they couldn't afford to take time off from work. And so despite our efforts to go where the patients were, this still clearly was not sufficient. I mean, we had 3 offices, one in Springfield, once a week in Quincy, once a week in Decatur, but there's still a huge swath of land that we could not cover. Now, mind you, here is Champaign, the other high-risk OB center, and they do a fantastic job as well. And I think there's some people from Carle Foundation Hospital, Maternal Fetal Medicine on the call. And so they cover this region, but you could still see there's a lot of Central Illinois that was uncovered. So here's the ultimate question. How do we provide high-risk obstetrical care to ensure that all patients have equal access? We tried going out to them, but we don't have enough manpower to drive to all these places. So what's the answer? Telemedicine. Telemedicine is the answer. SIU Maternal Fetal Medicine began telemedicine in 2017. And I do want to say that none of our program would have been achievable without the support by SIU School of Medicine and the great work by the SIU Telehealth Department, which is led by Executive Director Laura Kessel, who helped arrange this lecture. And we needed to get a buy-in from the School of Medicine, and they fully support this. And this is the way for us to provide optimal care. So just to briefly tell you what the workflow is. So scheduling is exactly the same. The referring general obstetrician or family practice provider or nurse midwife, they send us a referral with an indication, whatever it is. The patient comes to the office. We take her vitals. The sonographer does her ultrasound. While the sonographer is doing the ultrasound, I'm watching live from my Springfield office. And then when she's done with the ultrasound, she and I talk briefly, and then the patient and family enter the telemedicine office for a consultation, and I'm able to talk to my patients. And what I tell all my patients is that there truly is nothing different that I cannot do via telemedicine when compared to if I saw her in person in Springfield. Obviously, I cannot physically examine a patient, but most of what high-risk obstetrics and consultations consist of are reviewing the fetal ultrasound, discussing a pregnant patient's medical history, such as hypertension or diabetes, and then formulating a co-management plan with her general prenatal provider who is located in her community. And if she does need an examination, then I could contact her local OB provider, and he or she can do that. And if need be, the patient could then be transported to a higher level of care in Springfield. So just to give you an idea, this is a picture I took just yesterday. So this is my office where I'm sitting right now. And this was my telemedicine clinic in Jacksonville, Illinois, which is about a 45-minute drive west of Springfield. These are pictures that my sonographer took just yesterday. The reason it says fetus B is because this patient had twins. But by providing high-risk OB consultations via telemedicine, it gives me more time to see patients. I mentioned earlier that one of us used to drive to Quincy, and that was a 4-hour round trip. So now instead of sitting in a car for 4 hours, we have 4 additional hours to see patients if we stay local. Not to mention the commute to work on Thursdays went from 4 hours round trip, where I missed some of my kids' soccer games and basketball games. Now my commute is 30 minutes. Now there's definitely a need for telemedicine in less medically dense communities. And the reason why MFM providers are in great demand is because the number of women in this country who experience severe maternal morbidity and mortality is steadily increasing. 53,000 women last year in our country experienced some type of severe maternal morbidity, and that's defined by either having to be admitted to an intensive care unit or needing blood transfusions, or there are other parameters. And in fact, 25 million people of reproductive age reside in a county in our country that is without a high-risk OB provider. And there's very clear data that shows that the availability of a high-risk OB provider is inversely related to poor maternal outcomes and maternal mortality, meaning that if you don't have access to high-risk obstetrical care, your outcomes tend to be, you're at a higher risk for a poor outcome. The other issue we have is there's not a lot of MFM subspecialists in the whole country. There's only about 2,000 of us. And of those 2,000, 95% of us are in major metropolitan areas. So when I try to recruit an MFM physician, I'm competing with St. Louis, Chicago, and Indianapolis. So it is difficult to recruit to more rural areas. But again, telemedicine will now allow MFM specialists to see patients even if they're 500 miles away. And just to show you specific to Illinois, which I find quite striking, But in Illinois, and I went to the Society of Maternal Fetal Medicine website and also went to each perinatal center, and I counted 60 maternal fetal medicine doctors in Illinois. And of those 60, only 12 of us work within this red line. So there's 48 maternal fetal medicine physicians who cover Cook County and the collar counties, and there's only 12 of us. Again, only in Peoria, Springfield, and in Champaign are where maternal fetal medicine doctors are located. And I know several of them are on the call as well, and I would love to hear when we get to our discussion their comments regarding the challenges that we face in providing high-risk obstetrical care. So fast forward, this is South Central Illinois, or this is SIU Center for Maternal Fetal Medicine. This is our center, and this is the different telemedicine offices we have. So each red dot you see, we have a telemedicine site. So my goal when I came to Springfield 17 years ago, again, was we needed to have offices strategically located so patients have similar access to high-risk OB consults when compared to if they live right across the street from Cook County Hospital. Again, I want to demonstrate the reason we don't have offices here is because this is where Carl has offices, and Carl also has several telemedicine sites as well. So as far as the South Central Illinois perinatal network goes, I think we've done an excellent job in creating access to high-risk OB consults for our patients. But immediate action is necessary. And what I mean by that is we as healthcare providers need to figure out a way to improve access to all maternal care, high-risk care, routine prenatal care. We need to decrease maternal mortality. And what telemedicine is now demonstrating, although the studies are quite new, is that the use of telemedicine in obstetrics is beginning to demonstrate a decrease in maternal morbidity and mortality. This slide, every time I look at it, it's staggering. So this is a slide that shows the maternal mortality of industrialized nations. The United States, the maternal mortality rate, or the number of women who die either before pregnancy or immediately after pregnancy, is 4 times or about 3 times higher than the next industrialized country of France. Which is very scary. And this number is only increasing. So what telemedicine does is we're able to recognize which patients are high risk, and that way we won't have to care for them right when they showed up to our door with a significant traumatic and acute complication. By figuring out which patients are high risk, we're able to consult them throughout the pregnancy, and that way we're able to stratify which hospital they should deliver at. And just a few more slides before we get to our discussion. So this is from the Center for Healthcare Quality and Payment Reform. And I'm just going to read their quote. "It is not an exaggeration to say that rural maternity care is in a state of crisis, and a crisis demands immediate action. Every day that steps are not taken to implement the changes in workforce recruitment and payment increases, recruitment and payments, increases the likelihood that more women and babies will die unnecessarily." So when I think about what can we, because this really, it's a team effort. And my last slide after this is going to show you how many people it takes to take care of a pregnant woman. But what can Illinois do now to preserve rural maternity care? Well, one thing we could do is we can help rural communities in Illinois attract and retain a workforce. So I know, I've been at SIU School of Medicine for 17 years, and our mission is, quote, to optimize the health of the people of Central and Southern Illinois through education, patient care, research, and service to the community. So we train our medical students. We have 72 medical students per year, and our hope is a lot of them stay and work in Southern and Central Illinois to help with the critical shortage of care providers. We have an OBGYN and family and community medicine residency program where we train maternity care providers. And a lot of them do stay in central and southern Illinois, which is a testament to how the School of Medicine trains these physician learners. Local nursing programs need to place nurses in rural areas and provide incentives for them to work in these regions. We need to improve access to maternal fetal medicine care throughout rural Illinois. We need to expand our telemedicine program, especially in Carbondale. So I said earlier, we have the intention on recruiting a 5th physician, and we will keep recruiting enough physicians until we can care for every single pregnant woman in central and southern Illinois. And lastly, and just as important, is we need to discuss with our hospitals and insurance companies compensation. They need to pay adequately for maternity care services. You know, obstetrics, I say it's a round the clock business. Babies come on their own time. They don't come on our time. So maternity units, it takes a lot of resources to keep them open 24/7. You have to have anesthesia, nurses, physicians there to deliver the babies. So again, my final slide, it takes a village. Literally, it takes a village. And I wanted to recognize everyone who is currently playing a part to provide equitable and safe maternal care in rural Illinois. And I apologize if I forgot, I'm sure I forgot some people, but just to think about what do you need to have a successful labor and delivery unit and to provide accessible and excellent prenatal care, you need physicians. That could be an OBGYN, a family practitioner. Pediatricians and neonatologists are critical to take care of their babies and their critical babies. Nurse midwives, nurse practitioners, physician assistants, residents, medical students, the nurses on labor and delivery, nursing students, surgical techs, doulas, dietitians, lactation consultants, genetic counselors, social workers, environmental services workers, to keep our maternity units clean and sanitary. So again, I may have forgotten certain people, but the point of this slide is truly, we need to recognize everyone who's playing a part to provide equitable and safe maternal care in Illinois. And we must continue to work together to optimize maternal care in Illinois, despite the continued challenges we face. So I want to thank you again for giving me this opportunity to speak. And as I said earlier, I'm a 1993 alumnus of University of Illinois at Urbana-Champaign. So I may be a little biased. And again, my voice is lost from that Purdue game from cheering too loud 2 nights ago. However, I'm going to be optimistic, and I think this really could be the year for a NCAA men's basketball championship in Champaign. So I'll stop right there and give it over to Laura.
Yep. Thank you, Dr. Abrams. Great information. There's a lot of conversation in the chat, so I'm going to just start with some questions. This person says that there was a reduction in maternal service for a time at their local hospital in Vermilion County. A question they have is, what can local governments do to enhance access to rural health care?
Okay, there. Sorry, Laura. So what can local governments do to promote access? I think what we need to do is we need to lobby, and we need to go to our local governments as a group. And I think, you know, to be very objective about it, I think that's what's important. Objectivity, using the statistics I showed, because, and I grew up in Chicago, I trained in Chicago, I go to meetings in Chicago, and quite honestly, a lot of the healthcare that we provide in Illinois is, you know, in central southern Illinois is not thought of as strongly in Chicago. And I completely understand because the population is much greater there. But everybody on this call is from central and southern Illinois. We as a group need to lobby our local politicians, our local government, give them statistics and tell them this is what's happening in our region. And just stories tell a lot too. I think stories are very powerful. And I didn't get into detailed stories that we encounter on a daily basis, but all of the providers on this call could tell a story with a challenge they had and a near miss or even a worse outcome because of lack of access to regional hospitals, local hospitals.
Dr. Abrams, if I may, I'm a elected official in a countywide level, and I think one thing you can think about, especially in these rural communities, talk to your health department. Each health department has a board of health, see what services they offer, and there may be opportunity for them to apply for grant funding so that they can offer more services in the area. If maybe you have a shortage of healthcare services through your local clinic or hospital, but your health department may be a way to help backfill some of that. All right, someone said that they've had a handful in the last 2 years of babies being delivered in their cars due to the long drives delivering to a hospital. This person said they had a baby in September and had to drive 40 minutes one way for each appointment and to the hospital for delivery, and thankfully the scheduled delivery and not a surprise in the car. I think that happens.
I would say that happens on Interstate 72 once a month. We get a call, and I did not talk about our EMS team. I should have mentioned them, but our EMS team in Central and Southern Illinois have a lot more responsibility and a lot more ground to cover. So our perinatal team, I should have mentioned this, but at the South Central, and each administrative perinatal center has educators. So we have a neonatal educator and an obstetrical educator, and they go out to the different hospitals and provide drills, and they go to the various EMS firehouses, and they simulate a delivery en route. So the EMS team is well prepared and know what to do while bringing the patient to the hospital, because yes, it happens all the time. And I wish it didn't, but it's kind of a nature of the distance that these patients have to travel.
What type of cost is it to the patient if they have to be transported, ground versus air? And does insurance, if they have it, cover that kind of transportation?
That is a great question. So they will always cover ground, and others can chime in if I misspeak, but I have, for the most part, air is covered. I have heard from the Quincy population, and my patients are telling me that their providers encourage them to add on to their health insurance policy transport clause, so it'll pay for their air transport from. But I haven't heard any patient in 17 years come back and tell me, why did you transport here? And I'm stuck with a $20,000 bill. And that may be, it may be a lot higher than that. But really, when I go to Chicago, for example, and for a site visit, for example, I went to Cook County last year for their site visit, and it was unheard of them that they couldn't believe that we have an air transport service. And that just tells you how different and how much our challenges are greater in Central and Southern Illinois when to compare to Chicago. They call EMS, they put them in an ambulance, and 5 minutes later, they're at a high-risk hospital. That just doesn't happen where we are, and that's why we have to utilize an air transport service.
Vincent's Good Samaritan Hospital is close to some of the Wabash area counties, but health insurance may not cover out of state, and assuming Medicaid also does not cover out of state. If this is the case, those Southern and Wabash area counties are not in a good situation in terms of high-risk pregnancies, especially. Maybe a close hospital, but it may not be covered.
So I agree with that. So I had mentioned that the southwestern region, or it's called the Southern Illinois Perinatal Network, is based in Missouri, right? It's based at SSM St. Louis University. And in the past, it wasn't a huge issue. Illinois Medicaid was covered by them, but they're really cracking down in Missouri. So that is a great challenge. And that's why I had mentioned that we really, my next goal, our goal, and we've talked, my partners and I have spoken about this, is why do we need to recruit more people? Because we need to get into the region of Carbondale, because that's an area where patients sooner than later won't be able to cross state lines, and there's going to be a significant need for them to be transported to Springfield or Champaign.
There's some comments about doulas and midwives and them experience maternity care deserts, especially in Southern Illinois. There's a question about, are there other perinatal regions in Illinois that are also adding telehealth options?
I know that Carl does. Peoria, I'm not sure if anyone from Peoria is on. I'm not sure if Peoria provides telemedicine. And Rockford, from my knowledge, and I'm not 100% sure, but I don't think they do. And in in Cook County, Chicagoland, they really don't have a need for it because, again, it's much easier to get patients there. Now, you had mentioned doulas and midwives, and I can't underscore or understate the importance of midwives and doulas. And I'm serving on a panel right now through SIU regarding the recent law that Governor Pritzker passed regarding doulas being covered by Medicaid. And I think doulas are a great resource during labor and also throughout the pregnancy. We have a family nurse partnership. Like you mentioned, Laura, there are a lot of local groups that you can look, depending on where you live. Group prenatal care is another way to get patients. I mean, once a month, I used to drive to Logan Correctional Center, same thing, provide prenatal care for them because, again, I can't stress enough, everybody needs equal access. It's no longer an excuse that says, you know, some people say, well, it's the cost of doing business, right? You live in a small town, so you should accept the risk of your outcomes may not be as good as somebody who lives in Chicago. And that really is not validated, and that's not true.
If someone was interested in an MFM map for the Peoria region or North Central Illinois, how would they find that
I'm sorry, interested in MFM?
map for the Peoria region?
Well, Peoria, so that's OSF St. Francis. They're the Administrative Perinatal Center. That's the North Central Illinois Perinatal Network. So if you just contact OSF St. Francis and ask for the Administrative Perinatal Center representative, there's a director for each perinatal center.
What can state of Illinois or hospitals do better to recruit SIU graduates to keep them in Central Illinois? Rural hospitals are challenged when it comes to recruiting doctors.
Well, one thing, I've been on the admissions committee for SIU School of Medicine for 16 years, and we really, and I know there's a lot of medical schools in Chicago. There's only one, well, now there's Carl, but that's more, from my understanding, geared towards engineering. So if you think about it, in Central and Southern Illinois, there's one medical school. So our mission is really to attract students from these rural areas, students from Central and Southern Illinois. There's very good studies and research that says that you're going to end up practicing in or near the town where you grew up. So we recruit heavily students from Central and Southern Illinois. And not only just because they're from the region, but those who have the passion to serve our mission, which is to serve underrepresented areas. So, I mean, I think SIU is doing a fantastic job of recruiting out great students. The majority of students do stay in Central and Southern Illinois. But, you know, just from a maternal fetal medicine perspective, again, just from my own recruitment efforts, it's difficult to attract people because most people want to live in more, attractive areas. I think Springfield's a great place to live, but if you ask most people, they would prefer to live in St. Louis or Chicago or Indianapolis. But I just think there's such a need, and I get such a great reward. And I practice general OB in Chicago, and not to say I didn't enjoy it, because I enjoyed my patients, but there's patients are so grateful, and I think physicians that you work with, we're all in it together, and we all understand the challenges we face. So it's a different way of practicing medicine, and it takes a special person. But I think the people that are here at SIU School of Medicine are the right people to attract good students.
It's 12:59. I just want to mention that I know some of you need to drop off at 1. We usually lose folks right at the 1 o'clock hour. You got to get back to work. Nancy's going to go ahead and put a poll up so we can gain an understanding of what you learned today. But I think Dr. Abrams is willing to stay on, and we'll try to get through the final questions. Next question: are there any counties that you know of that aren't able to use telehealth options due to poor broadband infrastructure?
Laura, maybe you can answer that better than me.
Yeah.
So when I said that we couldn't do this without IT, all I do in the process is I say, I would like to open an office here. And my administrator, and Laura, I don't know what you do behind the scenes, but a month later you say, okay, we're ready for you, Dr. Abrams. So to me, it's very easy, but I'm sure it's not as easy as it looks.
I don't want to make too much of a blanket statement, but generally, I think hospitals and clinics, generally in most areas, those are where broadband is offered to those kind of center places first, whether it be a hospital setting or a school. Now, if you have patients that are staying home doing telehealth, that's a different story. But it seems like when we're having these telemedicine clinics in a hospital setting, generally, we're not dealing with some of those broadband issues we might be dealing with in the patients at home. I think that's fair to say. Not the case everywhere, but generally that's fair. One of the challenges we have in Illinois is the issue of malpractice. What efforts is your professional society making to deal with that issue?
Well, we all know that OB/GYN and delivery babies is the second highest risky profession, second to neurosurgery. And although pregnancy is a physiological, natural process, I think that's the issue, is everybody expects they're going to get pregnant, they're going to have a healthy pregnancy and a healthy baby. You have all these TV shows that focus on all the wonderful things that happen in pregnancy. And I'm a little slanted because I only see high-risk OB patients and I see the unfortunate outcomes. But having said that, most of our outcomes are still optimal. It's difficult. It's what I do tell the medical students, and I'm very passionate about this statement, is that don't go into a field that don't not choose obstetrics just because you're scared about being sued. I think if you're a empathetic physician and you practice good medicine, things are going to happen to everybody. Every single obstetrician on this call probably has been sued, and if not, will be sued in their career. And it has nothing to do with the type of care you give. And I'm not quite sure what we can do. I know there's been the medical malpractice crisis. I know Indiana has a fairly decent system, meaning before an obstetrical case can be brought forth, there's a medical expert panel. And I think that's a problem in our state, is it is so cheap it costs $100 or so to submit a lawsuit. So it's kind of like a lottery. A lot of the attorneys just throw hundreds of lawsuits hoping that one will stick. And it's just a burden to our medical legal system. I mean, that's the topic for a whole nother talk, but I guess my point is just, if you do what you're passionate about, don't choose something just because it's an easier lifestyle. And one real quick example, and I used this, a medical student a few years ago, wonderful student, loved obstetrics, and I thought she was going into OB, and she said, Dr. Abrams, I'm going into psychiatry. And I said, psychiatry? I thought you didn't like psychiatry. She said, I don't, but the lifestyle is going to be easier and I'm not going to get sued. And I said, that's no reason to pick a profession. If you have a passion for obstetrics, go for it. And, you just have to do your best.
Are you aware of any grants or a direction to be part of a grant in which you can lead us to get more income for our rural facility to stay alive?
I think, I don't know any specific grants, but I think hospitals need to work, and we do, but I think hospitals need to work even closer with Illinois Department of Public Health. They put out rules on what we need to do to provide care. And I think in order to fulfill and to follow those rules, we need, the adequate support to do so.
From a regional perspective, the other contributing factor that areas face is the lack of and delay with EMS services.
Yes, had been a huge dilemma over these last couple of years. So I made it sound sort of easy, where we get a transport call and we say, okay, we'll send our ambulance, we'll be out right now. But there is a shortage of EMS, both staff and physical rigs, but mostly staff. So even if you have 20 ambulances, if you only have 2 people to staff that, so there are some counties that only have 1 rig, and so they cannot leave the county to go pick up somebody outside that county. So that's another challenge. We're trying to be creative, and our MFM group meets every Wednesday, and this topic comes up a lot. How do we get our patients here the fastest way, but not just the fastest way, but the safest way as well? So we're utilizing a lot of one-way transport. So for example, Blessing Hospital, they have their own air transport. So a lot of times we just tell them to fly her one way, or if they have a local EMS. But that's, yes, I agree. In our region, there is a lack of services and a significant delay. And then what happens is these patients are stuck at these lower level hospitals where they don't have the resources. And that's why I said these doctors have the most difficult jobs at these smaller hospitals, because they have to deal with obstetrical emergencies with 1/10 of the staff that I have at St. John's.
And the babies may be delivered in the back of the ambulance as well.
Just happened 2 weeks ago.
Yes. Someone thanked you for acknowledging doulas as part of the team. Connecting families to doulas who can provide holistic in-person care is crucial to supporting families, especially in maternity care deserts. My understanding is that patients cannot be charged if air ambulance isn't covered under this No Surprise Billing Act.
Thanks, Dr. Gray. I just wanted to make sure, so I appreciate, just to let you know, Dr. Gray is my equivalent over at Carl. She's the director of obstetrics and maternal fetal medicine at Carl. So we work very closely together.
And I think the president just came out with a statement or executive order yesterday about ground and air ambulance and the No Surprise Billing Act. So things are rapidly changing, I think. So might want to look into just an announcement yesterday. There's a very short list of nationwide foundations that have grants to improve maternal health and prevent maternal mortality. Any that you know of that have been awarded in Illinois?
The only thing I want to mention, and I know a lot are familiar, we have the ILPQC, so that's the Illinois Perinatal Quality Collaborative. So that's a statewide grant, and there are other states, for example, California CMQCC does that. And basically what ILPQC does is they put out different safety measures and projects. So we did one project about making sure that birth certificates are adequate. One, it's called the MNO project, the Maternal Neonatal Opioid Project. So those are certain grants that are given to improve maternal health. Hypertensive disorder of pregnancy, that was a big one, where all hospitals that deliver babies now follow a very strict protocol in order to timely administer antihypertensive medication to minimize the risk of maternal stroke. So that's one foundation that I know of that's given federal money to run.
What about expansion in southeastern Illinois? That area has a far greater degree of desert designation than southwestern Illinois, and Evansville, Indiana is closer than Carbondale for some.
Yes, so Evansville, I do know for Robinson, Illinois, so that's a good example. Robinson, Illinois, Crawford Memorial Hospital, they're a level 1 hospital. I'm not sure how many deliveries they do, but not very many. But to get to us, it's 3 hours and 30 minutes by ground. To get to Carl, it's probably 2.5 hours. So they do utilize Evansville, Indiana, which is closer. But what I'm concerned about, what I'm seeing is the same thing I mentioned about crossing state lines into Missouri. So a lot of times these hospitals in Evansville aren't happy or don't accept Medicaid. And so I think as a state, we need to make sure that no matter where patients live, they need to stay within the state.
So sorry, go ahead, Dr.
So yeah, so that's a prime location to set up some telemedicine sites.
There's many thank yous and appreciation for this conversation today. I love that some people are asking questions and others are putting answers in for them and links, and there's contact information for the OSF Healthcare where someone was asking for a map. So thank you all for helping answer some of those questions. Someone mentioned that U of I's College of Medicine Rockford has the rural medical education, the RMED program, which also recruits students from rural Illinois, and there's a link to that site.
And Laura, I'll mention one more thing I didn't mention, but part of SIU too, although we recruit students from Central and Southern Illinois, we have something called the Lincoln Scholars Program, which is similar to Rockford, where we train people who only want to practice rural care. All 4 years are done in Carbondale.
Compared to national data, the SIU School of Medicine is at the 86% for placing physicians in rural areas. So that's a great statistic. Why don't we increase OBGYN residency slots and encourage them to stay local?
Well, I can answer about increasing residency slots. So residency slots are federally funded. And so there's only so much money federal money we get. And then specific to SIU residents, they're funded. We don't have an SIU medical center, right? Like Loyola University Medical Center, UIC. So our medical residents have to work at either St. John's Hospital or Springfield Memorial Hospital. So we get funding support from both hospitals. So, it's been a tough time in healthcare since COVID, and hospitals are financially challenged. So, but yeah, ideally it would be great if we can increase the number of residency slots. From my understanding, and it might have just started last year or this year, Dr. Gray, if you can confirm, but there's now an there's now an OBGYN residency program through Carl.
I think she's responding in the chat.
Oh, okay.
Okay.
Yeah.
Yes, 4 residents per year.
Okay, good. So that's increasing more. We need more healthcare providers. And
There's a-
in my experience, it's amazing. We have residents who came from California, and after they spend 4 years in Springfield grabs you, and they stay here. And that's a testament again to our training programs. But I think if they train here, the chance of them staying is much higher. So if we get more residents, we'll get more providers.
There's a follow-up to an earlier question. Are there specific actions local governments can take? We have a great county health department and we'll connect with them too for guidance. Does the web presentation for AHEC this week tie in? So that recording for AHEC is available already on the U of I website. There's probably going to be information in the email that Nancy sends out so that you are aware of that 3-part series. They did talk a lot about what they're trying to do in rural areas across the state during their webinar on Tuesday. To focus on rural healthcare education and workforce education and getting students when they're primarily college age, but sometimes a little younger, they're doing programming, health career exploration programming and preceptorships and placing students in hospitals and rural areas. So that definitely would be something that you might be interested in seeing, William. Go back to that presentation.
I just want to mention one thing because my partner, Dr. Sangroth, she made an excellent point. When you're an OB/GYN resident, there's a minimum number of surgical cases you need to do in order to be proficient and graduate. Obstetrics is not an issue. There are plenty of deliveries, but it's the GYN volume that is decreasing. And so it's hard to expand a residency program when you don't have enough cases. And there's been talk, and this goes back to when I was training, that maybe OB/GYN should not, maybe maternal health should be a separate residency program. Maybe GYN or gynecological surgery should be more surgical, and then maternal health should be more focused on obstetrics. But I just wanted to, that's besides the financial aspect of training programs, that's a real good point, is there's just not the GYN volume that could support such a large number of residents.
Someone made the comment, from their understanding, it's not necessarily the doctors you have to convince to come to a rural area, but sometimes their family because of quality of life and nightlife activity. We sort of had this conversation during Tuesday's webinar as well.
Oh, getting the providers' families?
Yeah, their spouse and yeah.
Well,
Yep.
on a personal note, my wife grew up in New York, close to New York City, right outside of New York City. And so we moved to Chicago. And she looked at the skyline and she said, "Where's the skyline?" And I thought she was teasing, but, and then we moved to Springfield and, so my point is, yeah, it's hard when you grow up in an urban area or even a suburban area to consider coming. But I think there's a lot to be said about living in a community like Springfield or Champaign or Macomb or Quincy. It's a lot closer knit. And, St. Louis is, an hour 20 to the west. Chicago's an easy drive, so it's easy.
Okay. I think that we've covered most everything. I apologize if I missed your comment or question. We so appreciate everyone joining us and spending time with us today. Thank you, Dr. Abrams, for your time and for what you do on a daily basis, and for everyone else that's working in this field. It's so necessary and important. We appreciate all that you do. Hoping we'll get a copy of the chat to Dr. Abrams so he can see all the nice comments that people put there. And again, this was the second in a 3-part series on rural health this month. Our next one will be on March 21st. We'll be talking with OSF On Call about their digital health programs. And as a reminder, Rural Partners and University of Illinois Extension partner in this webinar series, and we offer this throughout the year. So our next group of webinars are going to be focused a little bit more on local governments and resources for local governments. So thank you everyone for joining us. We hope we'll see you again soon and hope you have a great day.
Thank you.